Inflammation is a coordinated protective response to injury or infection. It is not chaos, it's choreography. Blood vessels dilate, permeability rises, and leukocytes are summoned and activated to eliminate the offending agent and clear damaged tissue. In its acute form, inflammation is fast and decisive, aiming to neutralize the threat and set the stage for repair. But remember the dual edge. The same mechanisms that protect can harm if unchecked. Mediators that dismantle microbes can also injure endothelium, extracellular matrix, and parenchyma. Keep that tension in mind as we move through the vascular and cellular phases, the mediators, and the molecular logic that ties them together. First comes recognition and attachment, often made efficient by opsonins. IgG and complement fragments, such as C3b, that tag the target and engage Fc and complement receptors on the phagocyte. Your figure labels a C3p receptor opsonin. In practice, this role is classically served by C3b and its receptors. Next is engulfment. The cell extends pseudopods, envelops the particle, and internalizes it into a membrane-bound phagocytic vacuole. That vacuole then fuses with lysosomes to form a phagolysosome, a chemical furnace. Inside, killing happens by two broad strategies: oxygen-dependent mechanisms driven by the NADPH oxidase respiratory burst, leading to superoxide, hydrogen peroxide, and via myeloperoxidase, hypochlorous acid, and oxygen-independent mechanisms using granule proteases, defensins, and lysozyme. Finally, debris is degraded and either expelled or presented as antigen. Each step is tightly regulated yet leaky enough that the same tools can spill outward, a theme we'll revisit. As neutrophils and monocytes crawl, chemotaxis, and eat, phagocytosis, their membranes are perturbed. That mechanical and receptor-level activation triggers degranulation and mediator release both into the phagolysosome and, critically, into extracellular space. Three classes dominate: lysosomal enzymes, oxygen-derived reactive metabolites, and products of arachidonic acid metabolism. Inside the phagolysosome they kill, outside they amplify inflammation and can injure tissue. Endothelial cells bear the brunt, their junctions loosening under the assault, which further increases vascular permeability. This is biological escalation. The products intended for precise killing also intensify the very inflammatory milieu that summoned the cells, explaining how a protective response can morph into bystander damage if uncontrolled. Summary of the acute inflammatory response. Start with the vessels. Arterioles dilate and capillary beds open, increasing local blood flow, the blush of rubor and heat, largely under the influence of histamine and nitric oxide. Permeability rises, allowing protein-rich fluid to exit. What forms is an exudate, not a mere transudate. Hemoconcentration and stasis follow. Now the cells. Neutrophils first marginate along the endothelium, roll via selectins, and adhere firmly through integrins whose affinity has been cranked up by cytokines. They transmigrate through intercellular junctions, PCAM1 helps, then follow chemotactic breadcrumbs, C5a, LTB4, IL-8, toward the source. At the end of this path, phagocytosis, killing, and degradation of the offending agent. Yet there is a cost. Extracellular release of toxic metabolites and proteases can damage host tissue, a price evolution has judged acceptable in the calculus of survival. All mediators have a biography. They originate either from cells, produced on demand or stored and released, or from plasma, where they circulate as zymogens waiting to be cleaved into action. Their production is triggered by microbial motifs and host-derived danger signals. Their actions are pleiotropic and context-dependent. The same mediator can nudge different cell types in different ways, and multiple mediators often converge on the same biological endpoint. Importantly, they are short-lived and tightly regulated, otherwise inflammation would never resolve. Keep these principles in view as we catalog the major families. On the cellular side, vasoactive amines, arachidonic acid metabolites, lysosomal components, platelet activating factor, cytokines, and reactive nitrogen and oxygen species. Each is synthesized or released from defined cellular compartments and acts locally, sometimes systemically. On the plasma side sit four cascades with switch-like behavior: the kinin system, bradykinin as the archetype, the clotting system, thrombin and fibrinopeptides, the fibrinolytic system, plasmin as both protease and complement activator, and the complement system, C3a, C5a as anaphylatoxins, C3b as opsonin. Think of these as interlocking gears. Activation of one can feed forward into others, amplifying the response with mathematical inevitability, unless halted by inhibitors. Histamine lives preformed in mast cells, basophils, and platelets, ready for immediate deployment. Upon IgE cross-linking, physical injury, or stimulation by C3a-C5a, histamine is released and binds H1 receptors to drive arteriolar vasodilation and increase post-capillary venular permeability, producing rapid edema. It also contributes to pruritus and pain. Serotonin, 5-hydroxytryptamine, is abundant in enterochromaffin cells and platelet-dense granules. When platelets aggregate, serotonin is released and can modulate vascular tone and permeability and influence smooth muscle, including in the bronchial tree. These amines are first responders, fast on, fast off, setting the initial conditions for everything that follows. Arachidonic acid metabolite, cyclooxygenase pathway. Phospholipase A2 liberates arachidonic acid from cell membranes. Cyclooxygenases, COX1-CoX2, convert it to PGG2-PGH2, the common prostanoid precursor. From PGH2, divergent synthases produce prostacyclin, PGI2, thromboxane A2, TXA2, and prostaglandins, PGE2, PGF2Y. PGI2 is a vasodilator and inhibits platelet aggregation. TXA2 does the opposite, vasoconstriction and platelet aggregation, establishing a vascular tug-of-war. PGE2 and PGD2 promote vasodilation, heighten vascular permeability, and sensitize nociceptors. PGE2 also mediates fever. PGF2-FAUD tends to constrict smooth muscle, including bronchial and uterine muscle. Non-steroidal anti-inflammatory drugs curb this entire branch by inhibiting COX enzymes, shifting the mediator balance and reducing pain, fever, and swelling. Lipoxygenase pathway. The lipoxygenase route converts arachidonic acid to hydroperoxyicosate tetraenoic acids, e.g. 5-HBE, and on to 5-HETE, a chemotactic cue in its own right. LTA4 is a branching point, converted to LTB4, a powerful neutrophil chemoattractant and activator, or to the cysteinoleukotrienes LTC4, LTD4, and LTE4. Those cysteinoleukotrienes constrict smooth muscle, promote vasoconstriction and bronchoconstriction, and markedly increase venular permeability, edema in biochemical form. Together, these products extend and focus leukocyte recruitment and edema formation long after the early histamine burst has faded. Neutrophils carry two granule systems. Specific, secondary granules hold lactoferrin, lysozyme, alkaline phosphatase, and collagenase, tools for microbial growth inhibition and matrix handling. Azurophilic, primary granules contain myeloperoxidase, acid hydrolases, and neutral proteases, the heavy ordnance. When released extracellularly, neutral proteases can degrade collagen, elastin, and basement membranes. Nature counters with antiproteases such as alpha-1 antitrypsin and alpha-2 macroglobulin, elegant brakes on runaway damage. Monocytes and macrophages contribute acid proteases, collagenase, elastase, and plasminogen activator, a repertoire that becomes increasingly important as inflammation slips toward tissue remodeling. Platelet activating factor, the whisper that becomes a storm. PAF is a phospholipid mediator, minute in amount, massive in effect. It's synthesized on demand from membrane phospholipids, typically via phospholipase A2 generating lysopaf. Then, an acetyltransferase snaps on an acetyl group to create active PF. No storage granules, no stockpiles. When you see it, it's because the cell has decided right now is the time to change the microcirculation. Who makes it? Platelets, of course, but also neutrophils, monocytes, macrophages, endothelial cells, and basophils. That diversity matters. It lets tissues amplify a tiny spark of injury into a well-coordinated inflammatory response. Receptor and signaling. PF acts through the PAF receptor, a G-protein-coupled receptor that couples primarily to GQ and GI. Think calcium influx, PKC activation, small GT paces, everything you need to tighten integrins on leukocytes, contract endothelial cells, and flip the vascular bed from calm to permeable. Functional effects. 1. Vascular permeability and vasomotor tone. PAF is more potent than histamine in increasing permeability. 2. Leukocyte adhesion and chemotaxis. It rapidly strengthens integrins and primes neutrophils. 3. Platelet activation, aggregation, degranulation, and thromboxane production. 4. Icosanoid crosstalk, amplification of prostaglandin and leukotriene production. Termination. PF acetyl hydrolase is rapidly inactivated. If clearance fails, systemic effects, hypotension, bronchospasm, shock follow. Remember, PAF doesn't shout. It whispers to many cells at once, and the tissue obeys. Local production first. Macrophages and dendritic cells release TNF-A and IL-1. Endothelial cells respond with adhesion molecules, chemokines, and procoagulant activity, endothelial activation. TNF-A, powerful, systemic effects when high. IL-1 overlaps but excels at fever and fibroblast activation. IL-6 orchestrates acute phase protein synthesis. Chemokines like IL-8, CXCL8 create gradients for neutrophil migration. Adaptive links: IL-12, Th1, IFN gangang, IL-17, neutrophil recruitment, macrophage activation. Counterregulators: IL-10 and TGF-beta dampen responses. Clinically, anti-TNF, anti-IL-6R, IL-1 blockers are major therapies. Cytokines are pleiotropic, redundant, and tightly regulated, resilient, but hard to shut off once in motion. Nitric oxide, NO, and reactive oxygen metabolites. Treat them as partners and sometimes adversaries. Nitric oxide, ENOS, endothelial, protective. NOS, neuronal. INOS, macrophages, high-output defense. Mechanisms: vasodilation via cGMP, protein nitrosylation. Early NO preserves perfusion. Later, INOS-derived NO joins microbial killing. Reactive oxygen metabolites: NADPH oxidase, superoxide. SOD, hydrogen peroxide. MPO, hypochlorous acid, bleach. Fenton reaction, hydroxyl radicals. Interplay: NO plus superoxide, peroxynitrite, damaging proteins and DNA. Clinical edges: ischemia reperfusion injury, chronic granulomatous disease, MPO deficiency, sepsis. Controls: antioxidants, SOD, catalase, glutathione peroxidase, NO scavenging by hemoglobin and ADMA. NO and ROS are not good or bad. They are force and counterforce. If confined, they sterilize the battlefield. If they spill, they burn the village.